Unit 22, Additional Resident Care Procedures. Applying heat. The effect of heat on skin and body tissue. The heat causes the blood vessels to dilate, so the blood vessels are going to get bigger, causing more blood to circulate to the tissues. This increased blood flow promotes healing as more nutrients and oxygen are carried to the tissues. Increased blood flow may also carry away excess fluids that are from inflammation cause pain in some conditions. So again, what that is saying is that the increased blood flow may also carry away some of the excess fluid from inflammation that causes pain. So it can help relieve pain. Moist heat application is more penetrating and can cause injury more quickly than dry application. And the effects of chronic illness and aging changes may cause the resident to be less able to sense the heat or pain, resulting in increased vulnerability to injury. Examples of heat would be warm soaks, disposable warm packs, and an aquamatic K-pad. It's a heating pad that has water circulating through it. So again, that is called a K-pad. Care precautions with heat application. A medical order is required for the heat application. The device is provided by the facility. Understand the method of heat application to be used. Follow the facility's procedure and review the procedure with the nurse as needed. Use the correct temperature as identified in facility procedure or on product use instructions. Apply to the skin correctly. Protect the skin from direct contact with heating device by covering the device with a cloth or other protective material. So you always want to make sure that there's something between the patient's skin and the heating device to help decrease the chance of any burns or any adverse reactions. Know the length of time for the application. Check the skin at frequent intervals while the heat is applied, and the resident may be unable to sense of imminent injury. So if it's supposed to be applied for 20 minutes, make sure that you're checking it and ensuring the skin remains uncompromised and checking it on regular intervals, and then to make sure that the heat is removed at the end of the duration. Remove the application at once if the skin appears reddened or is otherwise discolored, and notify the nurse immediately. Document the procedure and the results. What you did, how you did it, how the patient tolerated it. Applying cold. The effects of cold on the skin and body tissue. Cold does the opposite. It constricts your blood vessels, so it causes the blood to flow slower to the tissues. Ice or cold prevents or reduces swelling, relieves pain that may accompany swelling. It slows inflammation, and it can help reduce itching. Moist cold application is more penetrating and can cause injury more quickly than dry application. The effects of chronic illness and aging changes may cause the resident to be less able to sense cold or pain, resulting in increased vulnerability to the injury. Examples would be an ice bag, a frozen gel pack, or disposable cold pack. Care precautions with cold application. A medical order may be required for non-emergency use of cold application. Understand the method of the cold application to be used. Follow the facility procedure and product use instructions. and review the procedure with the nurse as needed. Apply to the skin correctly. Protect the skin from direct contact with the cold application by covering with a cloth or other protective material. Again, you want to make sure that there is something between the cold appliance and the patient's skin. Know the length of time for application and check the skin at 10-minute intervals while the cold is applied. The resident may be unable to sense imminent injury. Remove the application at once if the skin appears to be blanched, if it's very pale, if it's white or bluish in color, and notify the nurse immediately. And finally, document the procedure and the result. Again, what you did, how you did it, and how the patient tolerated it. As you can see with both cold and heat applications, the precautions are pretty much the same. They're just acting two different ways. Heat application is going to cause vasodilation, so the vessels are going to get bigger. This helps decrease edema or any excess fluid. Whereas the cold is going to cause vasoconstriction, or the vessels are going to get smaller and slow the blood flow, therefore decreasing the inflammation response or swelling from an injury. Care for the resident receiving oxygen. We have wall mounts, which are more commonly seen in the hospital setting. There are O2 tanks or canisters. Usually small tanks are used for temporary or emergency needs. In the nursing homes, when they're out of the room, you'll usually see them with a little bottle on the back of their wheelchair. Or in the rooms, you might see an oxygen concentrator or a machine that's plugged in, providing the oxygen. Or they may have a wall mount to where the oxygen is supplied through the wall. The wall mount then, the oxygen source comes from a very large container, usually someplace on the outside of the building or the facility. An oxygen concentrator, it removes other gases from the room air, leaving the oxygen for administration to the patient. So it sucks in all the air out of the atmosphere, but it filters it, and the only thing then the resident receives would be just oxygen. It gets rid of the carbon dioxide, nitrogen, all the other excess gases in the environment. It's larger in size, so it's usually kept in the resident's room. The smaller size is portable, allowing increased resident mobility. Devices: a nasal cannula. It's a small tube that delivers oxygen to the resident's nostrils. It's most commonly used device. A nasal cannula can be ran anywhere from 2 to 6 liters. So if you know that someone is on a nasal cannula at 3 liters, what you can do is you cannot administer the oxygen and turn the dial to 3, but what you can do as a CNA is to ensure that when you go into the room that you look at the regulator to make sure that it is set on 3 liters. If not, you would need to notify the nurse. An oxygen mask is also another device that can be used. It is positioned over the resident's nose and mouth. There are some different types of facial masks. There's a simple mask in which it can be ran at 6 to 10 liters. Then there's a non-rebreather which can be ran at 10 to 15 liters. So there are some different devices out there, depends upon the need of the oxygenation for the resident. Resident care measures. Know the O2 flow rate ordered for the resident, as I had just mentioned. Notify the nurse immediately if the flow rate is not at the ordered rate. Observe the resident's breathing. Report if they're having difficulty in breathing or dyspnea, or if they have cyanosis, report that immediately. Cyanosis is the bluish color in the skin, which is indicative of decreased oxygenation in the bloodstream. Maintain proper positioning of administration device. Check for pressure or other skin damage where the device rubs or presses against the skin. On the nasal cannulas, the most common cause to have some skin irritation would be around the ears, in which the cannula wraps up and around the ears and then down around the neck. Maintain the tubing free from kinks. If it is kinked, then obviously the oxygen is not going to flow into the resident. Provide skin care to administration site and provide mouth care. If they do have a mask or even a nasal cannula, it can cause drying of the oral mouth. So providing mouth care is very important. Remove oxygen administration device or discontinue oxygen flow only as directed by the nurse. So you should never adjust the flow rate, discontinue oxygen, or start oxygen without the direction of the nurse. If the humidifier is used with higher oxygen flow rates, check for humidifier fluid level. So the humidifier would have sterile water or maybe like saline water in it, and that helps humidify the oxygen. So if they have a nasal cannula, their nasal passage is going to become very dry, so the humidifier is going to help keep the oxygen moist that is going through the device into the resident to help keep the nasal passage again moist. Notify the nurse promptly if oxygen delivery system or administration device is making an unusual noise. And know where the facility's emergency oxygen supplies are stored. Very important to know, because if the nurse asks you to go get a bag valve mask or to get a simple mask or to get a nasal cannula, it's very important that you would know where you can go to get those. Anti-embolism or elastic stockings. I demonstrated these during one of our lab days to you on how to put them on, and I know some of you have had a chance to actually put them on in the clinical setting and found some other tricks to be able to put them on easier. But the purpose of the anti-embolytic socks are used to improve circulation for the residents who have certain types of poor circulation in their legs and feet. And they're used after surgery to help circulation in the legs, and it prevents formation of blood clots and an emboli, which is a blood clot that breaks loose and starts to travel throughout the body. So we want to make sure that if they are ordered, that we use the appropriate size and they are placed correctly. The resident care measures. Follow the care plan for schedule to wear and reapply. Often applied prior to getting out of bed and removed at bedtime. So a lot of times we'll have them on during the daytime and then off at nighttime. Because at nighttime they're laying in bed to where the legs are at least level of the heart. Sometimes even they might be elevated a little bit to help decrease the swelling. But if they were up and moving about during the daytime, they can develop what's called dependent edema, where the fluid goes down into the lower extremities and causes swelling then into the lower legs, ankles, the feet. So that is one purpose of using the elastic stockings, to help promote that circulation so they don't develop the edema. Apply while the resident is lying down, and this is the easiest, to have them lying down while you apply them. Apply so the stockings provide extra or even pressure and have no wrinkles, and check that the heels and toes are free from excessive pressure. So again, we want to make sure that there are no wrinkles to possibly impair the skin integrity. We want to make sure it is wrinkle free when you place them. Check them at intervals according to the policy. You need to check and make sure they have good circulation. The toes should be warm and pink. You want to check the stocking to remain smooth and completely extended. When the stocking slides down, the elastic can form a tight band, impairing the circulation. So we do need to check them at intervals throughout the day to ensure that we're not putting the resident at any risk for impaired skin integrity. Specimen collection. You may assist with collecting specimens of body secretions or waste. Understand the steps of obtaining specific specimen and verify with the nurse if you're unsure. Use standard precautions. Label the specimen container with the resident's name, date, and time. Place the lab request slip with the container. And store the specimen according to facility policy if you cannot immediately send it to the lab. So when you're collecting maybe a urine specimen, a stool specimen, a sputum specimen, we need to make sure that we're using the correct containers, we're using the correct technique to collect it so we don't cause contamination, and that we properly label it, because if it gets to the lab and it does not have the proper label on it, the patient's name, date of birth, your initials, the time and the date, then they will reject that, and you'll have to end up collecting another specimen, which delays test results for that resident. So make sure that you understand what you're collecting and the correct technique to use to collect it. We did talk about collecting specimen devices at the lab day, along with stool devices, or stool samples, I should say. Collecting urine stool specimens. A urine, provide for perinatal care for the female residents. Place a specimen collection pan or hat in the toilet or commode chair and ask the male resident to use a urinal. So you want to make sure that the female is clean and get rid of all that bacteria. That way we can get a clean specimen for the testing. And keep toilet paper and feces out of collected urine. If the urine does become contaminated with toilet paper or feces, do not collect the urine and send it off to the lab. For a stool specimen, place the specimen collection pan or hat in the toilet or the commode chair, or collect the specimen from a bedpan. Again, keep urine out of collected feces or stool, and transfer 1 to 2 tablespoons of stool to a container with a tongue blade without contaminating the outside of the container. So you take a tongue blade, which is like a little wooden stick. Usually a tongue blade you'll see the doctor use when they tell you to open up and say "ah." That's the tongue blade that they're sticking onto your tongue, so they can see in the back of your throat. So you want to again transfer 1 to 2 tablespoons of stool to the container with a tongue blade without contaminating the outside of the container. Restraints. Whenever you start at a facility, you always receive restraint training. Restraints are not used as much as they used to be. There has to be great justification for them, and they are not used for convenience. And they have to be well documented. So there's lots of things that go into the use of restraints. A physical restraint is a device near or attached to the resident's body that cannot be easily removed by the resident. It is also something that restricts a resident's access to his or her own body. Its intended use is for the resident's safety, for example, to prevent them from pulling on tubes or treatments. Examples of rails would be the bed rails, full rails up, half or on only one side of the bed. So again, if you have all 4 rails up, then that would be considered a restraint. If you have the rails up, what it's saying there, full, half, or only on one side of the bed. The trunk restraint is such as a vest or a belt. The vest wraps around the chest and the abdomen, and it ties usually in the back, and then it ties onto the bed frame. A limb restraint, it will take and it will just go around the wrist or the ankle, and then again it will tie onto the bed frame. And when you're tying something onto the bed frame, you need to make sure that it's not on the movable parts of the bed frame, such as maybe the rails. You would not want to tie it onto a rail, but you would again tie it onto the main frame part of the bed. And maybe a chair restraint that prevents the resident from rising. So you have them in a chair with the table locked in place. That would be considered a restraint because they're not able to move about freely. Before a restraint is used, anticipate unsafe behavior that the resident may attempt. Use alternatives to physical restraints. You need to anticipate the resident needs such as toileting, physical activity, thirst, or pain. Position for safety. For example, you want to keep the bed in its lowest locked position. and use cushioning landing pads at the bedside. And use security devices such as pressure sensitive pad in the bed or chair that sounds when the resident shifts off the pad. So that would be called a bed alarm or a chair alarm. So when those are set, they're set according to the patient's weight, and when it senses that the patient's weight is no longer applying the pressure onto that pad, then an alarm sounds. Restraints must be ordered by the physician for a specific medical purpose. Follow their care plan. Properly fitting restraint must be selected and applied by an appropriately trained individual. It must be the least restrictive device to be effective. Restraints are applied loosely enough for comfort and circulation, but tight enough to be effective. Applied smoothly to protect the skin from friction and pressure, and they're secured with a bow or an easily released knot out of the resident's reach. So anytime you do use a restraint, you must make sure that you use some type of quick tie on it, to where if there's an emergency and you need to get that resident out of bed or get them moving, that you can just grab it and release the knot or however you have it tied very rapidly. Restraints must be monitored frequently. According to facility policy, it is common that a resident and restraint are visually checked every 15 to 30 minutes. They have to be removed every 2 hours or more often as dictated by the resident needs. Check their skin, assist the resident to the toilet, and address other residential needs, and then reapply the restraint. Document the restraint use and resident care. Report any changes in the resident behavior while the restraint is in place, and restraint use can worsen resident behavior and contribute to injuries. That is the main reason why restraints are no longer used. One, they were being used as a form of punishment. So a lot of people would just put the patient in restraints, but then restraints also can cause injury. If the person's trying to fight the restraints to get out of the restraints, injury can occur. So, in summary on that, use restraints infrequently. We want to use them as infrequently as possible. We want to find other ways to help calm that patient or to redirect their behavior. Maybe they're confused and they're just wanting to pull on the tube. Maybe instead we can give them some washcloths to fold or some towels to fold. Maybe we can take them down to bingo, to an activity, or turn on a TV show that they want. But we could use some type of distraction to help instead of using restraints. Performing delegated tasks. You may be asked by the nurse to perform some tasks that are not included in this curriculum. Delegation of nursing tasks is appropriate in certain situations. If the facility, if they have policies that permit the delegation. So if you're trained, let's say in the hospital as a patient care tech, you're not trained in this class to insert a Foley catheter, but at the hospital you might be trained as a patient care tech to insert a Foley catheter. If you're delegated to do that and the facility allows, then yes, you can complete that task. But again, any type of task that is delegated by the nurse must be facility approved. The nurse has assessed the resident's nursing care needs and a written care plan has been formulated. If they have assessed the resident's need at the time the task is delegated, and they supervise you during the task. So those three things need to occur. The nurse needs to have made an assessment prior to the task, and they need to be able to supervise you during the task. The task to be delegated is performed according to an established sequence of steps and has a predictable outcome. It involves little modification from one resident situation to another and does not involve an ongoing assessment, interpretation, or nursing judgment. So for example, if you are ever allowed to insert a Foley catheter, the goal to insert a Foley catheter is to help drain the resident's bladder. So that would be the same on everybody. We place the catheter the same whether it's a male or a female. So it's not modified from one patient to another. And it's performed according to an established sequence of steps. So you must know the sequence of steps in order to properly place a catheter for safety. The CNA has received additional training and education to be able to perform the task. You've demonstrated competency to the nurse, and you understand expectations. The CNA evaluates your own preparation and informs the nurse if you need more training or supervision, and you may repeat back directions for the task to identify understanding. So those are extremely important for you as a CNA to make sure that you have received the additional training and education to be able to perform that task. Make sure you demonstrate competency to the nurse and understand their expectations. And you can do this by asking questions if you're not as familiar with it or comfortable with it. And you might repeat back the directions for understanding. Reporting. If circumstances change significantly, the CNA reports back to the nurse before completing the task and asking for direction. And when the task is completed, you report back to the nurse with any observations. So a few practice test questions here. Settings a CNA can work include hospitals, hospices, home care, A and B, or all the above. The correct answer is all of the above. CNAs can work in hospitals, they can work with hospice, they can work in home care, so all of the above. Who is in charge of formulating a work assignment? The head of the clinic, the patient's family, the head CNA, or the registered nurse on duty? Correct answer is the registered nurse on duty. Legal limitations that a CNA must be aware of while practicing healthcare techniques with his or her patients include: they cannot move the patient, they cannot take direct orders from an RN, they cannot advocate for patients in the field, they cannot take orders from a physician, or none of the above. So legal limitations that a CNA must be aware of while practicing healthcare techniques with his or her patients include: cannot move a patient, cannot take direct orders from an RN, cannot advocate for patients in the field, cannot take orders from a physician, or none of the above. And the correct answer is legal limitations that you must be aware of is that you cannot take orders from a physician, as we had talked about earlier in this course.